Dear audience, my name is Márk Pavlekovics and this is my PhD thesis about the current epidemiological and therapeutic landscape in Myasthenia Gravis, NMOSD and anti-MOG disease. I'm working as a neurologist resident in Jahn Ferenc Hospital, and my vision is a personalized therapy for neuroimmun patients, and my mission is introducing an up-to-date decision support tool for these patients in Hungary. This is a little overview about my works. Let's see the first topic, which is here is the title, which one is the plasma exchange might provide faster relapse control in critically worsening myasthenia gravis than intravenous immunoglobulin. Now we are in an article draft phase. We have already finished. I hope we can send soon to an internal review. As a background, I have to emphasize that more than 1,500 patients suffer from myasthenia gravis in Hungary. This is a neuroimmun disorders which affect the neuromuscular junction, cause skeletal muscular weakness. 15 to 20% of patients with myasthenia experience at least once crisis in their lives, with a high mortality rate. As you can see, in first case, the crisis is around 3 to 5% mortality rate, and the second crisis is more than 16. How we can prevent the progression? There are two tools. These are intravenous immunoglobulin and plasma exchange. From this coming the question, which one is superior? Which one have to use if we detected the worsening condition? IVG is expensive, there is a shortage of supply, and the mode of action is unclear. On the other hand, plasma exchange requires special equipment, trained personnel, and removes the applied therapy. There are no convincing evidences to support one over the other. So our aim was to compare the efficacy and safety of intravenous immunoglobulin versus plasma exchange treatment in patients with moderate to severe myasthenia gravis, and we hope we can add to clinicians' something about the interchangeability or the preferability of these two tools. Our clinical question is, of course, related to the hypothesis. What is the efficacy and safety profile of these two tools? Our PICO framework shows we work with adult patients, and our outcome was the changes on the quantitative myasthenia gravis score and the number of adverse events. The QMG score is a severity score which reflects the patient condition. The lower number shows us a better condition. We hypothesized on our previous knowledge that Plex is superior to IVG or our experiences. We conducted our systematic research in 5 databases with this search key. We found eligible 3 we found eligible 3 articles. One of them was excluded because the ineligibility for the statistical analysis. So these are my forest plots, included only 2 studies. The first one shows the efficacy measured on QMG scale in 2 weeks. There is a moderate heterogeneity. The mean difference is minus 2.8. Both of the studies prefer or favor plasma exchange, but there is no statistical significance. It's may clinical relevance, because this number means if we use plasma exchange, we can reach a better patient condition, and maybe we can eliminate one of them symptoms, because every symptom's worth 3 points. So yeah. the second forest plot shows us the number of adverse events in 30 days. There is a low heterogeneity, and the odds ratio shows us there is no differences between the two tools. We finalized the risk of bias assessment, which shows us the QMG scale is a low risk. So the efficacy measurement is belong in a low risk category, and adverse events in a high risk category. As a summary, I can say the strength of this work was we only used randomized trials with homogeneous population, and this is the first meta-analysis in this topic. As a limitations, there is a limited number of qualifying studies, and they use different treatment regimens. As a conclusion, we can get the plasma exchange might provide faster relapse control, but further research needed with uniform treatment plan, and yeah, this is that's what I can say as a conclusion. My second topic is organizing and building the Hungarian myasthenia registry. As I mentioned, myasthenia is the most common autoimmune disorders in which affect the neuromuscular junction. The incidence is in Hungary is around 20 per million person, and the overall mortality is 5 to 9. Myasthenia registry had not been established in Hungary, and we hope our hospital gonna be a good cornerstone for it, because the 60% of patients are in our hospital. So we aimed to create a uniform treatment plans by the register and analyze the epidemiological status and create an epidemiological landscape. And as a main goal, of course, we would like to analyze the mortality of the crises. We have a stable registry resources covered by a Neuroimmune Society. The data collection gonna be started in our hospital. It will be the pilot phase. We finalized the eligibility criteria, the request forms, and we finished the questionnaires and the forms, and now we are in a TUCAB license phase. I hope as soon as possible we can test our first ECRF. My third topic is about the update, the NMOSD and MOGAD registry. It was an ongoing study. I would like to emphasize it. Unfortunately, it interrupted in 2017. So first, we would like to update the data, and we decided to analyze mortality. And compare our mortality data with Denmark findings. We have finished the collection, and we have in Hungary more than 100 patients. 169 patients, and in Denmark 63. And we would like to compare the mortality and find out the differences if they have. And we are in the statistical analysis plan phase. So here are my specific goals with the plan submission date, and thank you for your attention with this quote: "Life is like riding a bicycle. To keep your balance, you must keep moving."
How much is the advisable plasma volume in case of plasma exchange?
Around 2-3 liters. It's depend on the department, but approximately 2-3 liters.
And do you know the side effects of plasma exchange?
Yeah, there are a lot of side effects. The main problem is the biggest. What I know is the myocardial infarct. It happened a lot of time, relatively a lot of time, and of course some allergic reaction. But it absolutely depends on the nurses, because the circumstances are very important. So.
Thank you for your presentation. I would like to ask if you are thinking about a clinical trial based on your first topic, because there is not really many articles in this topic.
For now, this isn't in our plan to write a protocol for it, but we will see if I have a time after the registers we uploaded. I would like to work with it, because it's absolutely relevant and a good topic, and we are in a very lucky situation, because both of the therapies are available in our hospital, so it's worth to do something with it.
I would like to ask that what is the current consideration when a clinician chooses between the EVIC therapy and the plasmapheresis therapy?
Sorry, what is the current
consideration when a clinician chooses between the two types of therapy?
It depends on the availability. There are many centers in Hungary for neuroimmune patients, but there are just a few of them where available both therapies. So it's depend on the availability first of all, and I don't know why one hospital choose only IVG or only plasma exchange. How I know, because from all of the Hungary were sent patients to us for plasma exchange. It's a complicated thing to do. So somehow treat patient with IVG, it's easier, because it's just an infusion, not a whole machine and everything. So I think IVG is worldwide more preferred.
I have a comment to your third project, because it's very interesting, and I would recommend you to audit the number of neurologists in Denmark per 100,000 patients, and same for Hungary. So I read I heard a lecture, similar comparison between Swedish and Croatian stroke outcomes, and there are 4 times less neurologists in Sweden than in Croatia, but the outcome is twice as good. So it's something interesting for you to consider.